Welcome back to the Core Ultrasound channel. Today we are diving into a new frontier in ultrasound-guided regional anesthesia, and that is the interfascial plane block of the shoulder, or IPB. Now this technique, it's showing real promise in the treatment of shoulder pain right at the point of care in the emergency department or in your clinic. Now, I'm excited to share with you my recent conversation with Dr. Gabe Rose, the co-author of a new case series that was published in the American Journal of Emergency Medicine relatively recently. Together, we explore how the IPB targets specifically the axillary and musculocutaneous nerves, some branches from them, through a simple anterior approach. Now, what's awesome about this block is that it spares the diaphragm and preserves motor function. This is a practical alternative to the traditional interscalene block for shoulder pain, because there are going to be situations where you can't use this. For instance, if you have somebody that you can't accidentally block the phrenic nerve when you're doing this, COPD patients, maybe patients with pneumothoraces on the contralateral side, maybe patients with oxygen requirements. This block, the IPB block, is much more motor sparing than a traditional interscalene block as well. Let's get into it. Hello and welcome to the Ultrasound podcast. My name is Jalen Avila and I have with me again the illustrious Dr. Gabriel Rose. We had Gabe with us to talk to us about carpal tunnel release in the emergency department, which has so many applications. And now what we're going to talk about is another case series on something I've never really heard about, and that is the treatment of shoulder pain with ultrasound-guided interfascial plane block. Now, Gabe, you are the co-ultrasound fellowship director and division director at Kaiser in San Diego, along with Deja Essner. And I'm so excited to hear about this. Teach me, because I want to treat my patients with shoulder pain.
Okay, thank you for that introduction also. So here's the thing about this interfascial plane block, and it's a very generic name that we couldn't think of anything better to call it. And it just, as the name implies, it's a block in the interfascial plane in the shoulder. So let's go into it. So first of all, this block is derived from some case reports and case series from the anesthesia literature. This is completely new, as far as I know, to the world of emergency medicine. And the idea here is that we're injecting at least a couple of nerves in this fascial plane that exists between the deltoid muscle and the subscapularis muscle on the anterior portion of the shoulder. So it's actually pretty simple. It's a plane block technically, and it's derived from a couple of different ideas, one of which is a pericapsular nerve group block of the shoulder, which this technically isn't because we're not getting into that shoulder joint, and a couple other techniques that I found. And I just kind of put that information together and put this block in writing.
Wait, it's like a ping block, but of the shoulder, or is there a ping block of the shoulder I'm not aware of?
Yeah. So let me clear that up. So there is a peng block of the shoulder.
I did not know that. There
is, yes. And interestingly enough, the paper that I drew this procedure technique from described this similar technique to being a peng block, but it technically isn't, because a peng block, you'd have to do this interfascial plane as well as deeper underneath the subscapularis muscle within the shoulder joint and inject local anesthetic into that region or area. And then you'd get a complete pericapsular nerve group, which would actually be very useful for shoulder surgery.
Got it. Okay, thank you. You teach me stuff every time we talk, and I love it. Now, let's talk about this block specifically. Generally, when I think about plane blocks, we're not targeting a specific nerve, but we kind of are, meaning it's not like a ulnar block of the forearm where we can see the ulnar nerve and we're targeting the ulnar nerve. We're targeting a fascial plane in which a bunch of nerves are kind of like floating in, like for instance, for the erector spinae block or the serratus or the tap block. What is the nerve, little fingers of the nerves that we're trying to anesthetize with this interfascial block?
So that's a good point. And this is different than most plane blocks. As you said, it's not these sort of terminal nerve branches. It's actually quite a little bit of a larger nerve. So in this plane, we have predominantly the proximal axillary nerve, or the axillary circumflex nerve. And that is the main driver for this plane block. And there's a couple of other nerves, and there is some variation depending on the patient's anatomy. But another important nerve here is the musculocutaneous nerve. So you're not technically hitting just the proximal axillary nerve, which is why I think it's more appropriate to call it a plane block, because it would be a multitude of nerves, anywhere from 2 to even 4 nerves, depending on the patient.
Brilliant. And so this is, okay, so I'm trying to think about this anatomically, the musculocutaneous nerve, that's going to be more kind of like out here, right? And then
Yes.
the axillary nerve is more kind of the lateral aspect of the shoulder joint and the deltoid as well?
Yeah, brilliant. Exactly. So when you do this plane block, and if you perform it well, you're really going to get coverage to about 40 or 40+% of the shoulder, predominantly the anterior superior, and the lateral portions of the shoulder. You're definitely not going to hit anywhere in the posterior superior or posterior inferior parts of the shoulder.
So what applications do we have here? Like, what patient would this be useful in?
So I think that's the beauty. I think it can be used for a wide array of patients, and that's why I like to perform this in the emergency department. So you can use it for patients with chronic pain syndromes like frozen shoulder, shoulder impingement. You can use it for calcific tendonitis. I've used it for shoulder sprains, shoulder strains. So all kinds of acute or acute on chronic painful conditions are suitable.
Would you be able to do it? I mean, this is the ER doc. Like, would you be able to do it by itself for a dislocation? Like, I don't know, that it seems like that's just targeting, just part of the capsule, not the whole thing.
Absolutely. So I think this is, I should say absolutely a good question. You can try to use it for shoulder dislocation or proximal humeral fractures, but what's important to realize about this interfascial plane block is it's a great form of analgesia to use in your multimodal analgesia in the emergency department. It's not shoulder anesthesia unless you went deeper, let's say, and went to that pericapsular nerve group and got into the shoulder joint, which we're trying to avoid anyway here. So it's not anesthesia. If you have somebody with a shoulder dislocation, or you have somebody with a proximal humerus fractures, or anything else that requires a deeper set anesthesia, I would recommend something a little bit deeper in coverage, such as a brachial plexus block, or even a combination of the suprascapular nerve block and axillary nerve block together.
Gotcha. I think that if we, this is just anecdotal, I don't have the actual data because I don't track my own patients that well, but I imagine chronic shoulder pain is probably way more commonly seen than a shoulder dislocation or proximal humerus fracture, which I like to keep that in mind because we, as ER doctors, I think we think a lot about what's the worst case scenario, right? But a lot of our patients come in with diseases and pathology that isn't life-threatening or limb-threatening. However, it dramatically affects their daily lives. They're constantly in pain. They can't use their arms. Let's say they need it for their job. And so you could argue that this, for chronic shoulder pain, is arguably more important. It would reach more people than doing an interscalene block, for instance, for dislocation. What do you think about that?
I 100% agree. I think that, and the interesting thing is that it kind of adheres to this phenomenon where, that old saying, it's like, you want to buy a car, and the minute you start thinking about that car you want to buy, you start seeing it everywhere. Well, this sort of had a domino effect for me. And when I started doing this interfascial plane block, I noticed that I was using it more and more and more on shift, because I found that, again, it applies to a broad array of applications. So, for example, I recently had 2 patients on 2 consecutive shifts. Both had chronic rotator cuff syndrome, chronic rotator cuff tears, horrific shoulder pain. Both of them had done something that I guess irritated or flared up their shoulder dysfunction, and they came to me looking for help. They had already done NSAIDs. They had done some topical lidocaine. All of them have been through physical therapy. At this point, nothing was helping. And I was very wary of starting them on opioids because, well, one of them flat out just didn't want to do it. The other one was older, and I just didn't want to have any respiratory compromise. So, in other worlds, you start thinking about this patient is in 10 out of 10 shoulder pain, maybe we'll do an interscalene block. But if your patient is obese, has COPD, you really just can't afford to lose that nerve function, that motor function altogether. There's a lot of risks and dangers that come with a dense nerve block like that. So I said, let's do this interfascial block. It's fairly simple to do. And I performed it, and both the patients had dramatic effect, where even though it's an analgesic procedure, not anesthesia, they were able to range their shoulder to a larger extent than they had before. One of them said, I can finally sleep at night, I think. And I was able to send them home, just continuing on some acetaminophen and an outpatient follow-up. So the effects are pretty dramatic, even though it's only about a 40% improvement in that coverage of the shoulder.
I do have a full separate video on how to perform the interfascial plane block at the shoulder. I'm going to insert it right here so that if you don't want to, you don't have to watch 2 different videos. You can just watch it all on one video. Check it out.
Today we're going to be performing the shoulder interfascial plane block here. So for this block, you're going to have your patient laying supine. You're going to have just a pillow behind their head here. And what you're going to have them do is you're going to have them externally rotate their shoulder with just a little bit of abduction here. So once you have them in the proper position, what you'll do is you'll use your flat linear probe. And you're going to go ahead and put your probe in a cephalad with your probe marker going cephalad. And you're going to put that right over where the humeral head is. And what you're looking for on your ultrasound machine is you're going to be looking for the deltoid, and you're going to be looking for the subscapularis tendon and where that junction is. So where you're going to be aiming your needle for is actually just in between the deltoid and the subscapularis tendon, just above that myotendinous junction. So once you have your patient prepped and draped and in the proper position, you've identified your landmarks on ultrasound, what you'll do is you'll use your 1.5 inch 25 gauge needle with your local anesthetic, and you're going to insert your needle from the cephalad orientation using an in-plane approach. So once you have everything set up, you're going to go ahead and use your needle, like I said, at that cephalad in-plane approach. Aiming for that junction of the deltoid and the subscapularis tendon. So now I'm going to start hydrodissecting that area. You should see a nice lifting of that junction here. Very good. And you'll see that nice unzippering here. And you'll instill about 20 cc's of your local anesthetic. Very good.
That was how to perform the block. Now on to the rest of the podcast. Well, I mean, I would argue that I think that things aren't all or none, right? Like if you can lower someone's pain by, let's say they're a 10 out of 10, you bring it down to 5 out of 10, that's like still pain, but that is like something that maybe you take some Tylenol, some Motrin, a light, Robaxin, some light muscle relaxer, and maybe that brings you, all of that would bring you down to a 2. I think assuming that a block, just any block would automatically, it doesn't work if it doesn't bring you to 0 pain. I just don't think that that's really feasible or realistic. And I actually tell any patient that I'm doing a nerve block, I never say, I'm going to get rid of your pain. What I say is there is a high chance that this will lower your pain. That's what I say. And then if we're lucky, it might get rid of your pain, but lowering the pain is the goal.
Setting expectations is extremely important. And I say, if I can achieve a 40 to 50% reduction in your pain, then we've won. And I find that oftentimes I exceed that, but if you set that expectation, I think that you can meet it, the patients will be very satisfied and realistically, just be satisfied taking an NSAID or acetaminophen or something like it.
Now, I'm trying to think of other injections around the shoulder. One of the ones that I have been performing recently, and this is with patients with frozen shoulder, is a subacromial bursa injection, which I've honestly had pretty good success with. I do a small bit of Kenalog and then a small bit of lidocaine, and it seems to work pretty well. How is the subacromial bursa injection different than the interfascial nerve block?
In a few ways. The first important thing is when you're doing the subacromial subdeltoid bursa injection, the transducer positioning, which people often employ, is on a coronal plane along the acromion on the sort of superior aspect of the shoulder, overlying the supraspinatus muscle. The injection target itself is the bursa sac. So you're trying to introduce that needle under ultrasound guidance into that bursal sac and inject your local anesthetic plus minus a steroid. When we do the interfascial plane block, the patient positioning and the transducer positioning is different because the target is different. So we're having the patients usually in a sort of semi-recumbent position. I'll usually keep the head elevated to about 15-20 degrees on the gurney. And I'll just have them comfortably abduct their arm out a little bit and externally rotate the hand to deliver or pull out the subscapularis muscle from the shoulder. The transducer itself is placed on that anterior deltopectoral groove and shifted just a little bit laterally over the humeral head to visualize the subscapularis. So now we're lower down on the shoulder than doing the bursa injection, and we're looking at a different muscle, not the supraspinatus, but more so the subscapularis. It's very similar in appearance to doing the bursa injection because it's often in the same sort of plane linearly, but the needle itself is not going in a bursal sac, it's just going into that intermuscle plane between the deltoid muscle and the subscapularis.
That makes sense. And for this, what are you injecting? I guess, are you doing the D5W? Are you doing steroids? Are you doing local anesthetic?
I'd love to do a study where I inject D5W because it does have some nerve calming effects and there could be some compression there. But in actuality, I'm trying to mirror the literature from anesthesia. And in the original reports that I read, they were using 0.25% bupivacaine and about 20 ml. Which I've done. And since publication of this paper, I've actually shifted my approach a little bit. So what I'll tend to perform is an injection using a solution of about 10 mLs of 0.25% bupivacaine and about 5 mLs of 1% lidocaine with epinephrine. And then the rest of the syringe, I'll fill with normal saline or D5W just for that volume, because in these case reports, and case series that I derived this procedure from, they usually use anywhere from 15 to 20 mLs to cover that plane. And the reason I moved away from just pure bupivacaine is twofold. Number one is when I introduced the lidocaine with epinephrine, I just anecdotally seem to have a little bit of a faster onset, and I like the idea of the epinephrine having that safety profile, as well as decreased absorption of the anesthetic, so for longer effect perhaps. The other one is, whenever you're injecting 20 mLs straight of bupivacaine, although this is still technically well below the toxic dose range for most of the adults we treat, I am always a little bit wary of bupivacaine as compared to other long-acting anesthetics because it tends to have a little bit higher of a side effect profile. So just for pure comfort, even though it's still below that toxic range, I kind of pull back a little bit on the bupivacaine, add some more lido with epi, and the rest with some saline. Got
it. Now, with this, I'm trying to think about other blocks. I know that one of the things, as you mentioned, that we worry about is the very likely, I tell my residents, assume that 100% of the time you're causing some paresis of the diaphragm on that side, because it's right there. If you think about that phrenic nerve and where it lies when you're doing an interscalene block, it's a very low chance that you're not, to some degree, getting it. But remember, most patients don't notice, right? It's just the ones that you mentioned that might need to access all of their lung, whereas most of us can tolerate one one of our hemidiaphragms not working super well for a short period of time. Now, I know if we move down to the supraclavicular brachial plexus block, it lowers the incidence, but it still happens. Is there any chance with the interfascial block where it might go back up, especially if you're using a larger volume, and affect the phrenic nerve?
That's a great question. So far, that has not been explored in the literature, and there's no indication that it would. I think the chances just are extremely low. I've done this block at this point maybe about 30 times, and I don't think I've seen that happen at all. And I usually keep my patients for monitoring because even though, again, we're below toxic levels, anytime I'm injecting more than 10 mLs of a local anesthetic, I just like to be very precautious, keep people on a monitor for an hour, and assess their cardiovascular function. And not a single patient has had any issues with their diaphragmatic function, at least in a subjective sense of any shortness of breath, anything like that. So you're well away from that phrenic nerve when you're doing this block. You're in the shoulder area. So theoretically, and at least anecdotally, you should not have any type of hemidiaphragmatic dysfunction. And it's also, in its nature, a heavily motor-sparing block. You get very minimal motor involvement, so it's mostly just analgesic sensory.
Got it. This seems like an amazing block that I've done once, and it was, after I read your paper, your phenomenal paper. And my N of 1 so far, it's worked really well, and it worked in the emergency department. So I'm excited about it. Now, when I was reading the article, I noticed that there was some letters to the editor, and I was wondering if you wanted to kind of discuss those.
Sure, I'm happy to go into it. So I should say initially that I find, and I wonder if other people out there feel the same way. Emergency medicine, we're kind of considered a younger field, even though we've been around for quite some time. And oftentimes when we do things that push the envelope, like adapt techniques from other subspecialties like anesthesiology or pain management, we tend to get letters to the editor on these papers pointing out discrepancies or trying to critique our approach. And in my mind, I like to think about it as like peer-reviewed trolling. But in actuality, I think some of it comes from people just being concerned that it's somebody without their specialty doing these procedures. But I think people have to remember that as emergency medicine physicians who have subspecialized or have utilized ultrasound for procedural technique, we're not new to this as we used to be, decades ago, and we have a good amount of experience and precision of performing these procedures, and we take as much safety and precaution as we can whenever we employ these. So at this point, I just welcome those papers, and I'm always happy to respond and clarify my point. Certainly, there's always a little bit of an imposter syndrome that comes into play, and you start to immediately worry that you did something wrong, but I think that people are still kind-hearted, and I just like to be kind-hearted back when I respond. I'm never belligerent or too defensive in any of these letters.
Yeah, I'm with you. I mean, I think most people mean well, and part of me wonders how much of it is the familiarity with what we do. I actually tell my residents this frequently when there's consultants that need reminders that we are equivalent, like we're equals. We don't work for our consultants. We work with our consultants to benefit our patients. But I think about sometimes how many consultants, I mean, even in our healthcare system in the United States, they don't really know what we're capable of. They don't know what we do on a daily basis. For instance, like an anesthesiologist that maybe doesn't know that we can't cancel an intubation because it's too difficult or the patient's too unstable. Like that's what we intubate. That's what we're good at. I remember showing a cardiologist, hey, like I think the patient, has kind of borderline tamponade, and I showed them my clips and my reasoning, and this cardiologist had no idea that we could get echoes and that we knew that, you get left atrial collapse during systole before you get ventricular collapse during diastole, and that it has to be like greater than 1/3 of the cardiac cycle. Like they don't know that we know that stuff. And so sometimes just some gentle education, even if the words that they use, you wouldn't have used, right? Like they're maybe like not the most kind of like kind words to use. I think that it's important for us to use kind words back, answer the questions, but more importantly, to advocate for ourselves as really, I think, really good practitioners of medicine.
I agree. And I think ultimately it comes down to the patient at the end of the day and what we can do to help them the best we can and offer them the best. And sometimes the best solution is the simplest solution. And that's why multimodal analgesia is so powerful, because we're trying to get to the root of the problem. And doing these types of injections targets that specific area, and it helps us avoid heavy use and prescription of opioids and NSAIDs, which obviously can cause problems.
Yeah, totally. Well, I can't wait to do this block more, and I can't wait to talk to you again. Gabe, it was wonderful to have you a second time on the podcast. And I'm excited to do this more because you have such amazing insight on pain management, on ultrasound in general. Now, before we go, do you have any shouts out for, it could be about anything. It could be like a nice movie that you liked. It could be the people that helped you write this paper. It could be anything.
I have to give credit to my current resident, Samir Metri, and my former fellow, Carlos Gonzalez Cobos, who both helped me on this paper and went in cavalier fashion and got these blocks done with me in the emergency department. So thanks, guys, for your efforts. Of course, shout out to Kaiser Permanente San Diego Ultrasound Division. Find us on X. Find us on Instagram at kpisano if you want to see some cool 30-second or shorter videos on using ultrasound to better your care.
Awesome. Well, I can't wait to see more from you and to learn together.
Thanks for having me.
That was my interview with Dr. Gabe Rose on the interfascial plane block for the shoulder, a diaphragm-sparing, motor-sparing technique that could become a game changer for patients with shoulder pain in emergency settings. Now, again, this is not great for shoulder dislocations or fractures, but for all other causes of shoulder pain, it should dramatically diminish the amount of pain that patient's in. If you're interested in incorporating this block into your clinical toolkit, check out the full paper linked below for images, technique breakdowns, and pearls from the case series. And if you want specifics on how to actually perform the block, check out the 5-minute Sono video on this technique. Don't forget to like, subscribe, hit that little bell for more content on ultrasound-guided procedures, ultrasound-guided imaging indications, and evidence-based innovations in emergency medicine. Thanks for watching and happy scanning.